Good afternoon, everyone. So that's my topic is enucleation versus evisceration. When and how. Generally, for the general public, it is enucleation is a removal of the total removal of the eyeball, entire eyeball. In true sense, the loss of eyeball, yes. But is it destructive? No. And most of the time we can go for we can use it as a constructive surgery also. Is it a minority procedure? The answer is no. It's a need a lots of skill for that. Next, what is actually evisceration? It is a surgical removal of the content of the eyeball, not as a whole eyeball. So generally we can preserve the sclera is a common type, but nowadays we can use a cornea sparing techniques also. So that's time is I want. So for in some, especially in injured patient, in traumatized patient, it is very, very difficult to convince. In such cases, cornea sparing is one of the best option. Again, it is not a destructive procedure. We always prefer it is a constructive procedure, not a minority procedure. Or it mostly it is a cosmetic surgery for us in most of the time. So why we can consider it is a cosmetic surgery? Possible for proper volume replacement because we can equalize the volume. Almost symmetrical look. I am not saying that symmetrical, almost symmetrical, good movement, special custom-made prosthesis, and in cornea sparing technique is very, very informative. But as it was in my talk, it was a why and when. So choice-wise enucleation versus inversion. It just remain controversial in certain circumstances. Those are some published reports are there, but most of the reports now in trends like that. As the sympathetic option is less, so we can go for a evisceration also. Evisceration is relatively simple. We may go for a scleral implant or we can go in a scleral quadrification, but this is mandatory nowadays for better cosmesis. We can implant the ball proper size blood with proper technique. This is a very much important this. So as I mentioned, we can go for a standard evisceration until and unless there is some medical problem, then most of the time we can go for along with the primary evisceration implantation, there's a ball implantation. There's lots of techniques. We may go with standard evisceration technique with relaxing incision. We can make a posterior cut and we can go for a 4-quadrant technique. We can go for a transcleral technique, whatever. Our aim is to just do a better cosmesis. On the other hand, in that enucleation, as it is total removal of the eye, there's a lots of other material. We can implant the ball in the cone itself without any suturing, without any that material. But sclera is the one of the best to cover, and we can suture all the muscles for better cosmetic look. So one of my patients in a small, she was due to the injury, evisceration was done, and I just open up the sclera and then a implantation done, and this is the good shock and this is the look. In evisceration, an implant is placed within the sclera. As I already mentioned, there may be so many relaxing posterior sclerotomy or might be standard techniques, but in enucleation, we need one other material like a sclera or other materials. Or without the ball, sometimes perforated ball we can implant, but this is mandatory for each and every patient to go for. Why evisceration and evisceration, there is some controversy. One very important point is sympathetic ophthalmia. Earlier in the era 20 years or 30 years back, there was a high incidence of sympathetic ophthalmia following trauma. That time probably the medical facilities was not as good as, and steroid was not used most of the time. And that's why there was some sympathetic ophthalmia. But now in today's era, the sympathetic ophthalmia is very incidence is very low. Or even there is a sympathetic ophthalmia, we can treat the eye very easily. So in such cases, so better we can go for a evisceration rather than enucleation. And another point is the motility and cosmesis. There is a lots of debate on motility and the cosmesis, but there is some studies that Nakra, T, Ben et al. Etc. They are studied 84 patients in a very meticulous way. As per them, there is no such gross difference. They are telling us not gross difference, but however, these claims cannot be made based on the retrospective analysis. Points against eviscerations are, but there is some indications where there is a points against. Those are some technical. One is scarred orbits or thysis bulbi, but I am at present doing in thysic bulbi also with some modified techniques with evisceration. But some are definitely, there is some definite contraindication like intraocular tumor, suspected malignancy, diagnostic and research purpose. For diagnostic and research purposes, generally we need a enucleation is better for doing SPE. But whatever the way we want to do, we must do a implant, primary or either it may be a secondary, but primary is always better. Options remain variable when considering enucleation versus eviscerations, primary versus secondary, implant. Placement is depending on the situation. Generally, this is a mandatory process. This is a little bit about that. There it may be a non-integrated, or it may be integrated, or it may be autogenous. But nowadays, with non-integrated is very useful, is cost-effective, and it's very rewarding. So then next is that we can go for, as I mentioned, it was a long back evisceration was done. So in such cases, we can go for a donor sclera and we can use it. And those are some surgical steps. We can open up the conjunctiva. We can meticulously open up the tenons. Then we can use a eye bank sclera and we can implant the ball inside, susar it, and we can implant like a ball. And it was the earlier socket. This one, the next socket, where it is very good. There is a shallow, there is a deep socket superiorly, shallow in the inferior, uneven socket. But with implant, we can modify some amount. We can superiorly we can push it, and we can reduce the sulcus deformity, and ultimately there is a ideal. But though it is an ideal socket, but that here is not, the sizes are not as equal. So need a proper prosthesis. But the main advantage of ball, which those are a porous ball earlier, that is if we are implanting little bigger size, there is a chances of extrusion expulsion. If there is a infection following the operation, there may be some extrusion exclusion. Those are the important in both the conditions. It may be in following evisceration, following enucleation. But as I already mentioned, our work is up to the surgery, but the role of ocularists is very essential. These services may include cleaning, polishing, enlargement, reduction, and replacement all. So we can proper size, we can maintain, and we can prepare like it, and there is some which is not possible to cover up all sides. So suppose in this old patient, yes, evisceration down long back, huge sulcus defect, shallow fornix, also we can manage in such a way. So with a better cosmesis. So occupational rehabilitation is one of the very important component following evisceration and enucleation. So the eye care provider should provide a affordable artificial eye to the patients as a very essential component of rehabilitation. But it is not, I always against the stock eye is generally decreased. One of the lady evisceration was done. So she just maintained her hairstyle and just that one. And with that secondary ball implant, it can be easily managed. So, aesthetic point of view, though few studies said that there are no difference between enucleation and evisceration. However, there was an overall trend that evisceration patients has a better subjective scores in fornix and sulcus separations than enucleated patients. So, in my take-home message, the decision is largely based on surgeon's preference and the experience. With evidences, literature, other supports. So, basically, frankly speaking, evisceration is slightly easier process, and most of the time we can perform in general anesthesia. For the cost effective point of views, suppose in young age, maybe 16 years to 18 years, in some patients it is very very difficult to convince enucleation, psychological point of view, and to convince inside the OT under local anesthesia. So this is another important factor in our country, like where socioeconomic condition is one of the factor. In such scenario, we can go for. I prefer specially evisceration over enucleation is a low incidence of symptomatic abnormal in today's era. It is already proved and comparatively easy and better in terms of cosmesis. It is easy in the surgery over the enucleation. And cosmetic point of view, as lots of other authors also mentioned, it is easier for this. So